So for risk adjustment, I've learned a lot over the years, but I am not a risk adjustment coder, nor am I certified in it, so I'm probably going to rely a lot on Chandra for this part. But what exactly does an HCC coder do, and would I be eligible for HCC work as a CPC-A?
Okay, so actually both of all of these risk adjustment questions came in from the same person, and there's a lot of good information to share here, and it's kind of hard to summarize it quickly, but I'll try. So what exactly does an HCC coder do? Well, you'll find that I tend to correct you if you say you are an HCC coder. You may be an HCC coder, but you work in the field of risk adjustment. And HCC is just one type of risk adjustment. This particular person said, you know, I Googled HCC, and it's really just coding to the highest level of specificity, right? Yes and no. When we talk about risk adjustment and how risk adjustment differs from day-to-day coding operations in a physician practice, risk adjustment is based on chronic conditions affecting a patient and trying to project, based on all of the patient's chronic illnesses now, what kind of care they're going to require next year. And risk adjustment and HCC coders typically work for the insurance plan, usually. Whether they work directly for the insurance plan as a subcontractor for a company working for the health insurance plan. There are more that are starting to work in a physician office or for a specific hospital or health group, but the vast majority of the time, at least historically speaking, they have worked for insurance companies. And the reason for this is, let's say I'm a physician and I report my claims to my Medicare carrier, right? I send in here are all my claims for my Medicare patients, and that Medicare carrier then pays me based on a fee schedule, whatever we've agreed to, whatever I've accepted contract on, accepted assignment, and that's how I get paid. Well, if the Medicare carrier that I'm billing to is a Medicare Advantage plan, right? Humana Gold Choice, some of the Blue Federal plans, United Healthcare had some of these plans, right? There's all sorts of different ones out there, but if they're a Medicare Advantage plan, the purpose of a Medicare Advantage plan is a patient trades in their traditional Medicare Part A and Part B in exchange for this Medicare Advantage plan that covers everything and usually has a better deductible or better coinsurance or offers some added benefit, whether it be prescription drugs, a silver sneakers plan where they can go to a gym, different things like that. Well, those Medicare Advantage plans, the way that they are funded, they're funded by the federal government, but they get paid from the federal government not based on a fee schedule, not based on the CPT codes and RVUs like a physician typically does, but instead they get based on a risk score. How risky is this patient? How much are they going to require in treatment next year, right? Based on everything that we've had to do for them this year and last year, how much are they going to cost us next year? How much are these chronic conditions getting worse? And are they going to need more care? Are they going to need to see more providers? Those types of things. So what that risk adjustment coder usually does, or that HCC coder, is they have a list provided from that insurance carrier that says, here are the chronic conditions that we get paid on. And oftentimes, here's the documentation that is required. Because it's not enough for a physician just to say, oh, in the medical history, patient has diabetes. Did they address the diabetes in any way? Did they renew the medications? Did they tell them to keep taking their meds? Did they ask them about their blood sugar levels? Did they do anything to evaluate systems that could be affected by the diabetes? The eyes, the neurologic system, the kidneys, all of those different pieces. So really what an HCC coder is doing is reviewing the note from a different perspective. Instead of just saying, what did you address, treat, or what impacted your care today? Yeah, we want all of those things, but from a chronic condition perspective, what things may have affected the care and what things may have you addressed that you didn't really spell out that you addressed in the assessment and plan, and how can we help you better document those pieces? So yes, it's all about level of specificity, but it really focuses on chronic conditions.
Right.
Can you be eligible to do that work as a CPC-A? Absolutely. And we're actually seeing a lot of risk adjustment groups, risk adjustment
prospective employers.
prospective employers, thank you, because that was not coming into my head, that are hiring CPC-As, and they do it for a couple of reasons. One, you don't have any bad habits that I have to teach you to do the opposite of, right? I don't have to get rid of them. The other is that almost all risk adjustment prospective employers provide training of their own, because each health plan is slightly different and there are little different rules. So while I can teach you the kind of the basics of risk adjustment, how it works, and what Medicare says here are the rules, each health plan may have a little different interpretation of what qualifies as appropriate documentation. So they're actually going to teach their employees, I want it done this way, and here are the explicit rules you have to follow for us on this plan. And sometimes if you work for a third-party billing organization that's subcontracted with one of these carriers, you may have to learn multiple different plans, right? If it's Anthem, you do this. If it's Aetna, you do this. If it, depending on what their rules are. I think I answered.
And we're finding too that I don't want to reveal too much, but anyway, we're talking with a large group that employs risk adjustment coders, and for years they always wanted them to get their CPC. Well, now with the new CRC credential, they've recently changed their policy to where now they want them to get the CRC. So, Chandra's always said that you don't have to get your CPC and then do CRC. You can actually go right to the CRC and not even really mess too much with the CPT manual and focus on ICD-10 and risk adjustment. So we're actually going to be releasing, I think in tomorrow's newsletter, a risk adjustment package that includes our full ICD-10 course plus our risk adjustment course, which goes over all the, basically and coding concepts as well, but the two together are great. So a brand new person to the industry could actually do those two courses, take the CRC, and go look for these prospective employers that are looking for risk adjustment coders and be very well trained. So that's very exciting, I think. And then you only have to worry about one code set, right?
Right.
Get one code set in your brain.
We actually have somebody in the Facebook chat. Barbara completed our class, and she's actually working in the risk adjustment field, and she said it's a lot of different things. Every day there's something new, and she's one of those that works for a third party, so she's dealing with a different plan at different times, and the rules really do change. That's why I say when you attend a course, anybody's course, whether it's ours or somebody else's on risk adjustment, we can't teach you everything. We can give you the benefit of our experience. We can teach you how the code set works, what the codes are that risk adjust for the different plans, whether it's Medicare, whether it's the HHS plans, and sometimes even the CDPS codes that adjust. But again, those vary by state. But it really comes down to which specific plan you're working with and what their rules are, what they feel is good and what they feel is not good. And it may differ greatly from the plan next door and what they're doing.
What I'm noticing in the industry in all the years that I've been around is that things are shifting from just being a coder, like translating a medical document into codes, into really understanding the bigger picture and understanding the reimbursement structure behind it so that you can be more effective at your coding. And it's just like when I was in high school learning calculus or whatever, you could plug the formula in and maybe get it right all the time, but until you really understood why the formula worked, you didn't get that aha moment, And it's the same with coding. When we understand why for outpatient we do it differently than we might do it for inpatient, then it all gels and makes sense, and you can be an advisor to the providers that you're working for. You can catch mistakes. You can see opportunities left on the table that the provider was entitled to reimbursement for, and the opposite, protect them if they're doing practices that would get them in trouble in an audit. And so, that's the trend that is really happening, where coders are actually getting, their roles are becoming more elevated in what we're doing. We're doing a lot more auditing and things like that. So really understand the payment methodologies. Even if you don't work in a particular setting, it's important to understand, at least from a general sense, how they work. And even so much so on the CIC exam, which is the inpatient credential, they do ask you some outpatient related questions, and vice versa. On their COC exam, which is certified outpatient coder, they ask you a few inpatient questions to make sure that you know. At first that really bothered me. I'm like, outpatient should be outpatient and inpatient should be inpatient, but really to be good at either of those roles, you should have a little bit of knowledge, you know, of the other one. So.
Well, and to kind of dovetail onto that, risk adjustment in particular, I can't tell you how many providers accept Medicare Advantage patients and are contracted with Medicare Advantage plans, but have no idea how the payment structure is different for those. Because what they see, I'm paid on a fee schedule. I don't care about diagnosis. It doesn't impact me until somebody explains to them. The way that the insurance company who is paying you on this fee schedule, the way they get their money is based on the diagnoses you document. So if you see that your fee schedule is being reduced, that you've got insurance carriers that are dropping you, because we're seeing this, they're calling it narrowing networks, right? They're getting rid of those physicians who aren't doing what they need them to do so that the insurance company can get the reimbursement they need from the federal government. If the physician's not doing their part, what's the easiest way for the insurance company to fix that problem? We'll drop that physician, right? Find a physician who documents appropriately so that we can get our money so we can afford to pay that physician. It really, once you explain that to them and they start to see the big picture, that's when they have the aha moment as well. And you'll begin to see improved documentation. You'll begin to see physicians who do worry about diagnosis coding. And they start asking those questions. Long before I got into the world of risk adjustment, I would have people say, you know, my physician doesn't think there's any value in diagnosis coding and being specific, especially when we were still in ICD-9, right? It was a much more vague code set. There weren't a lot of specific options. Providers would document very broad diagnoses. And what I would always tell them is, you know, talk to your physicians. And the minute that they say that they're upset that the hospital can't afford the equipment that they want to use to do a test, remind them their documentation, specifically their diagnoses, contributes to what that hospital is able to bill, right? Give them that big picture, and you'll see some improvement. You'll see some changes.